Hello, everyone. Welcome to our live talk on outpatient joint replacement surgery. Before we begin, we'd like to ask that you submit your questions via Zoom throughout the presentation. Once Dr. Ferguson has concluded his presentation, I'll read those questions off to him. A brief introduction of OrthoSouth. We offer comprehensive orthopedic care across 7 clinic locations in the Mid-South region and have 2 surgery centers, one in Germantown, Tennessee, and one in South Haven, Mississippi. Now to introduce our speaker, Dr. Ferguson. Dr. Ferguson is a dual board certified fellowship trained orthopedic surgeon specializing in sports medicine and orthopedic surgery. Dr. Ferguson earned his medical degree and completed his orthopedic surgery residency at the University of Mississippi School of Medicine, and he also completed an AO International Trauma Fellowship in Switzerland. Dr. Ferguson received his undergraduate degree in engineering from the University of Mississippi, and when he's not at work, Dr. Ferguson enjoys spending time with his family, reading, participating in outdoor sports, and being involved with local athletes, as he is the team doctor for St. Mary's and has also worked with Brighton High School and Cordova High School. So I invite you to sit back and listen as Dr. Ferguson shares his presentation on outpatient joint replacement. Take it away, Dr. Ferguson.
Okay, thank you. Thanks for joining us. And as she said, I'm Chris Ferguson here with OrthoSouth. I've been here for 15 years, and I'm one of the surgeons that performs outpatient joint replacement surgery through our surgery centers. And what I wanted to talk about tonight is just kind of go through some of the questions that I'm routinely asked by patients who come in to discuss knee and hip replacement surgery. Many of them have had joint replacement previously, 5 to 7 to 10 years ago, and they come in and say, how is it possible that you guys are now doing these as an outpatient when I had this surgery done 10 years ago and I stayed in the hospital for 3 or 4 days, and it was a slow process, and I just can't fathom going home the same day. And so I wanted to kind of go through the advances that have come about that allow us to do that, and talk about the process, just to give you some additional information about that. So outpatient joint replacement surgery. What we'll talk about tonight is traditional joint replacement surgery, what makes outpatient joint replacement surgery possible, who is a candidate, what to expect. Traditional joint replacement surgery typically involved 3 to 7 days in the hospital. When I was doing my training as a resident, 15 to 20 years ago, everybody stayed at least 3 days. I can't remember routinely ever having anyone go home sooner than that, typically more like a week. Anesthesia was a general anesthesia. Pain was controlled with IV opioid pain medications with PCA pumps, where patient had a little controller in their hand, and they would give themselves pain medication every so often. Tended to cause a lot of sedation and sluggishness. There was significant blood loss. About 30% of patients needed a transfusion. We would oftentimes have people donate their own blood, called autologous blood donation, ahead of time. So they would actually have that blood transferred to the hospital, and in many cases we would give that back to them at the end of the surgery or the next day following the surgery. Everyone got wound drains, would stay in for a couple of days. Pain catheters by anesthesia were femoral nerve catheters that were placed high on the leg, and they would stay in for a day or two and kind of drip in some pain medication. One of the downsides to those is that they knocked out the femoral nerve and would cause a lot of quadriceps muscle weakness and would slow down mobilization. So here you go. So what were some of the consequences of all those things? So there was slower patient mobilization. In many cases, patients would be admitted following surgery, and they wouldn't get their first session with physical therapy until oftentimes the next day. And just the whole process was slower. They would, as I said, stay in the hospital for a few days, and then maybe not get PT as an outpatient for a few days after they went home. Limited physical therapy. In the hospital, anyone who's been admitted to the hospital knows that you spend most of your time sort of laying in bed. Try to get people up to the bedside chair, but again, most of the time people are spending the majority of their time simply laying in bed. There was a high utilization of inpatient rehab, so patients would have surgery and stay in the hospital for, as I said, 3 to 5 days, and then oftentimes would go to an inpatient facility for up to 2 to 3 weeks, and again, spending a lot of their time laying around in bed. So what were the complications that we saw with that, with the limited mobility? So limited mobility leads to blood clots, pulmonary issues, pneumonias, constipation, and ileus, and just general deconditioning. Patients would get actually weaker from not being up and about. So then there was a transition phase, and I would say this is, in the maybe 7 to 10 year past. There's a medication called tranexamic acid, which I would have to say is probably the biggest advancement for me in my career with total joint replacement. It's an agent that we give before and after surgery that actually helps control blood loss. And without question, without this medication, we would not be able to do total joint replacement. With tranexamic acid, people rarely, in fact, I can't remember honestly the last time I had a blood transfusion with the total joint replacement. It basically has almost eliminated the need for routine blood transfusion for routine surgery, hips and knees and shoulders. The other thing is started to do spinal anesthesias instead of general anesthesia. The femoral nerve catheters changed to a single shot, what's called an adductor canal block. It's a nerve block, but it's performed lower in the thigh, and it typically spares the quadriceps. So you don't have that muscle weakness, and allows people to mobilize much quicker. And so what we started to see again in the 5 to 10 year past is that those 5 to 7 day hospital stays started to turn into overnight stays or two night stays. And so that was, what I kind of call the transition phase from the traditional, week in hospital to a shorter hospital stay. As we mentioned, the tranexamic acid, I think the biggest advancement is simply that, just less blood loss, and one of the key factors in letting us to do these as an outpatient. Short-acting spinal anesthesia, so not only are we doing spinal anesthesia, we're using a shorter-acting agent so that the sensation and motor function returns much faster. So when patients come out of surgery in the surgery center, their legs start to wake up and they can start to work with physical therapy and mobilize with their walker, move around faster. Another big advancement is just improvement in pain management, and we depend heavily on our colleagues in anesthesia, but the pain blocks are better. We've worked out a regimen of medication, including non-steroidal anti-inflammatories, Tylenol, limited opioids, cold therapy units, which help reduce swelling and pain, and then various types of joint injections that the surgeon injects into the tissues around the surgical site during the procedure. And in many cases, we don't use, on knees, we don't use tourniquets. In fact, I haven't used tourniquets routinely on knees since about 2018. So with the tranexamic acid and some of these other techniques, we just don't have the blood loss that we typically experienced years ago. Okay, so who are candidates for outpatient joint replacement? Really, most people are people that are generally healthy, patients that are motivated and like the idea of recovering at home, and patients that have good home support. I do probably 70 to 75% of my total joints now as an outpatient. There are still some patients with particularly significant medical comorbidities, heart issues and things that we need to keep overnight just to monitor. But again, the majority of patients that I see are candidates for joint replacement as an outpatient. So what are some of the things that patients can do to get ready for surgery? I get asked that question quite a bit. and we'll go through some of that. So weight loss is important. The lower your weight, the lower the risk of complications, better wound healing, and better longevity for the implants. Regular exercise, a healthy diet. Smokers, we ask smokers to stop permanently if they can, if not permanently, at least for what we call the perioperative period, so the weeks before and after surgery, to optimize their bodies to heal wounds. Optimize blood sugar, so diabetics, there's a test called the hemoglobin A1C, which is a measure of blood glucose control over a longer period of time, and so we like for those numbers to be under 7 if possible. 7.5 is our limit. So if it's above 7.5, we have to have that corrected or improved through our colleagues in internal medicine and endocrinology. So preoperative pain medication. So we like to have patients that are taking opioid medications prior to surgery to try to taper off of those or minimize those so that we can better control pain after surgery. Steroid injections. So these are injections that go in the joint itself. So if you have an arthritic knee or hip and you've had a cortisone injection in the joint of the knee or hip within the past 3 months, we delay surgery until that time frame to minimize the risk of infections. Any dental issues, we like to have those corrected before surgery as well. And then we stop any of the agents that can cause additional bleeding, aspirin, NSAIDs, vitamins. Optimizing home environment. So people that have a upstairs bedroom, we like to try to have arrangements made so that the patient can stay downstairs for a short period of time until they're able to better negotiate stairs safely. Rearranging furniture so that you can get around with your walker. I like to have all of my hips and knee patients on a walker for the first 2 weeks just to make sure their balance is good and reduce the risk of falling. Remove throw rugs. So those are notorious for causing falls. People's feet get tangled up in them. The walker gets tangled up. So we just ask that you put those in the attic for a period of time until you have your surgery and get over the surgery. Shower modifications, just the shower bars and things to help the grab bars to reduce the risk of falling. Pre-cooked meals, have lots of patients do this. They'll cook up some meals and throw them in the freezer, and that way it just facilitates the meal preparation after surgery. If you have pets, it's a good idea to consider boarding them or having a pet sitter so that it's one less thing that you have to do while you're focusing on recovering from your surgery. Okay, so what's the pre-op process? So the first thing would be just a consultation with your surgeon. Come in and meet your surgeon, have some x-rays made, physical examination to figure out if you in fact are a candidate, and if you're at the point where you need surgery or if there are other things that can be tried first. Many patients require a routine clearance from their primary care provider, which is basically just getting routine blood work, sometimes a chest x-ray or an EKG. If the patient has significant other comorbidities like heart or lung issues, oftentimes we'll ask the cardiologist or the pulmonologist to weigh in and let us know if there's something that needs to be done before surgery to optimize those conditions and minimize the risk of complications. We talked about labs and chest x-rays and EKGs. Then we'll have you meet with our anesthesia provider at the surgery center just to kind of go through those labs and things and make sure from the anesthesia standpoint they feel comfortable with having that procedure done at the surgery center. Patient navigation. So all of our total joint patients are assigned a patient navigator, who is a person that will communicate with you frequently, kind of keep up with things and call at certain intervals, both before and after surgery, just to make sure things are on track and make sure your questions are being answered and answer any questions that you have. There's a joint class that we have those navigators teach, and that's also some of the nurses in the joint center that will kind of give you, alleviate a lot of the anxiety with the process by explaining all of the steps before you go through the surgery. And the day of surgery, so you will come in, arrive at the ASC, you'll meet your pre-op nurse, meet with your surgeon and the anesthesia provider. You will typically get a pain block in the pre-op area, and then you will go back to the OR where the anesthesia doc will provide a spinal anesthesia. Surgery is performed typically in 1 to 2 hours. You head to recovery after that, and let the spinal anesthesia wear off. You'll mobilize with physical therapy. And once you're safe with therapy and pain's controlled, you will go home. So these are little animations. I've got one for the knee and the hip, and I think patients find them helpful, because I find that a lot of times people have a misconception of what is actually being done with the total knee. Many patients I have found think that we go in and basically cut your femur and cut your tibia, the bone below your knee, and just put a big metal hinged component in there, and it's actually more of almost like a resurfacing, and I'll show you when this gets going. So when we get down to the bones of the femur, the bone up above and the one below, we'll make these cuts on the bone, and these correspond to the components that go in. And you have a cap on the femur and a cap on the tibia, and then a spacer that goes in between, and that's what makes your knee joint. But many of the ligaments that run alongside the knee, the medial and lateral collateral ligaments, stay in place. Okay, and this is another animation that shows hip replacement. So we get down to the ball and socket joint of the hip, and we remove the arthritic femoral head and place a metallic socket within the hip socket on the pelvis, and a femoral stem that goes down into the femur, and an artificial ball. And that creates a artificial ball and socket joint, which is no longer painful because there are no nerve endings and no bone-on-bone contact there in the hip. Okay, post-op. What are some things that you can do at home? So at least for knees, I think the most important thing is adequate icing and elevation to control the swelling. So all of our knees go home with what we call a cold therapy unit, which is kind of a wrap that goes around your knee, and it's attached to a hose that goes down to a ice, like a cooler, and you can have keep that filled with ice and water, and that circulates cold water around the knee, and that helps minimize swelling. It also consequently helps dramatically with pain. So outpatient PT, which is very important, particularly for knees. I typically recommend 3 times a week for 6 weeks with knees, and 2 to 4 weeks with hips, although hips, many people can get away with less PT. I mean, it's not as important with hips as it is with knees. You will have an aquacell dressing. So the aquacell dressing is a waterproof antimicrobial dressing that allows you to shower from day one. You can't sink it down underwater. You can't put it in a bath or jacuzzi, but you can shower, and that is patients like those, and that's made reduce risk, reduce infections, and just keeps the incision nice and clean. Walker, as I said earlier, I like to have all of my hips and knees on a walker for the first 2 weeks, just to minimize the risk of falling and to kind of get their bearings and make sure their balance is good. Aspirin, so this is for blood clot prevention. So we use an 81 milligram aspirin twice a day for 4 weeks. And as I mentioned earlier, you'll have a patient navigator that will be in frequent communication with you, making sure that all of your questions are answered. You can certainly call the navigator. You can call, obviously, the surgeon's office, and you know, there will always be a person that you can get in contact with. Follow-up is typically in 1 to 2 weeks with your surgeon. And so the process is evolving. So we're still learning. We've been doing these now at the ASC for about 3 years, and we have a group of surgeons on the total joint, what we call the total joint committee. We track all of our results, and we sort of are constantly monitoring the orthopedic literature, what's being done elsewhere, and paying attention to things like the antiseptics we use and the skin prep, the types of injections that we do for pain control, the medications. We've changed the medications that we use for post-op pain control a few times. The dressings, the Aquacell dressing was one of the things that we mentioned, and just always on the lookout for ways to improve and make the experience better and reduce our risks. So what are the benefits of outpatient joint replacement? So without question, it's more comfortable to recover at home than in hospital. I think I can't think of a single patient that I've done, if I've done one joint in the hospital and later on done another in the surgery center, I can't think of a single patient that has ever said, you know, I like the hospital experience better. They've all said, this has been amazing, and you know, this is how I want to do these going forward if I have to have any others done. It allows for faster mobilization for all of the reasons that we discussed earlier. Patients seem to have less post-op pain, and our infection risk is lower than surgery in the hospital. Okay, so that's the formal presentation, and happy to go through any questions that you might have.
All right, everyone, if you would please submit your questions through either the chat feature or the Q&A feature. Dr. Ferguson, we do have one question. Are you open to using either the Cori or Mako robotic systems for joint replacement?
I am, yes. I've been trained on both the Cori and the Cori navigation system, and then the Mako robotic system. The Cori is a system that we have in the surgery center, and for me, I use it in cases where I think it's going to make the surgery easier. So the biggest indication for me is if they have existing hardware. So if they have had previous surgery, they have a rod in their femur from a previous fracture, or they have screws and things around the knee from other surgeries, that the robotic system will make that surgery easier, in that you don't have to place the alignment rods and things within the bone. So in those situations, it makes it easier for routine patients with regular arthritis without hardware or huge deformities. I typically will do a traditional knee because I think it's a little smaller incision, a little faster surgery. I typically don't use bone cement on any of my knees unless the bone quality is bad. And so for me, I think patients get very good result with a traditional system, unless, again, they have special circumstances.
Dr. Ferguson, which OrthoSouth locations do you see patients at?
I work out of the Exeter location, the Bartlett location, and the Poplar location.
And do you do more knee or hip replacements?
Probably 2 to 1 knees. I think that's been the average for me for many years.
Okay, and then someone asked, they said, how different is the robotic? I don't know if you mean what's the difference between the robotic systems, or how does a traditional differ from a robotic? Ma'am, if you're interested in learning about the robotic knee replacements, you can look on our YouTube or our website. We have information on there. Then what kind of material do you use for a hip replacement?
For hip replacement, so I use a striker system, and the actual femoral stem is called an accolade stem. It's primarily titanium, and we use a titanium cup with what's called a polyethylene spacer, which is the kind of the plastic component, which is the soft component between the femoral head and the hip socket, and then the femoral head I use primarily as a ceramic head.
Now, Dr. Ferguson, we had a lady ask if she would be a candidate for this type of hip procedure if she has arthritis in her right hip. Where would you recommend this lady starts to see if she is a candidate?
Yeah, I think she would just need to come in and see, one of our joint replacement doctors and have an evaluation, have x-rays, and see, how bad her arthritis is on x-ray to begin with. That's sort of the starting point. And then we typically ask, to see what other treatments have been tried, if any. And many times we can manage that arthritis for, some period of time without surgery, with either oral medications or injections or some of those things, physical therapy.
Thank you, Dr. Ferguson. If you're interested in making an appointment, you can go online to orthosouth.org or call our phone number. It's, I believe, 901-641-3000, and make an appointment with Dr. Ferguson or any other providers. Someone wants to know, if they see you in the office, will you be their surgeon?
Yes, sure.
All right, we have a couple more questions. Nope, sorry, they just said, someone said thank you, Dr. Ferguson.
Okay.
All right, we'll take a quick second and get any last minute questions. Thank you all for submitting questions. Okay, Dr. Ferguson, is there anything you'd like to say before we conclude?
No, I think that's it. I appreciate everyone joining, and we're happy to see you in the office.
All righty, well, thank you all so much for joining us this evening, and Dr. Ferguson, thank you for giving your presentation.
You're welcome. Good night.
Have a good night.